She's still here. Yeah, I'm sure she's ready. Okay, okay, all right. Yep.
morning, everyone. It's my pleasure to welcome everyone today to the public listening session. So this is the listening session, the public listening session on prescription drug coupons. So the first thing I want to do is welcome everyone and thank you for coming here. Thank you for giving us advice, for laying out the issues as you see them, for helping us think through this. The purpose of the meeting today is for us to obtain stakeholder feedback for a legislatively mandated study regarding utilization and impact of prescription drug coupons and other product vouchers. So the HBC was charged with this through, I'm going to just look down. Numbers correctly, through Chapter 363 of the Acts of 2018. And so we're to do a report, and we've already been working on the report. The way that the session this morning will run is, first I'll ask David if he wants to add anything to the intro. Then second, Sarah and Yue are going to give us an introductory presentation of the topic. They're going to explain what our statutory responsibility is and then introduce focused questions to guide the public comments. Anyone who is here is welcome to offer testimony, either in person or through written comments. There was just outside a sign-in sheet for anyone who wishes to testify. I have 4 names on the sign-in sheet, but if anyone wishes, please feel free to add their name or people can decide at the end they wish to add their name. We ask parties to keep their comments to up to 5 minutes. We are pleased to accept written testimony, and written testimony is accepted up till May 24th, 5 p.m. May 24th is this Friday? Is the 24th this Friday? Yes. Okay. The 24th is this Friday, so up until this Friday is 5 p.m. So those are my opening remarks. David Seltz, let me ask you if you want to add any opening remarks before we turn it over to Sarah.
I don't, other than to thank you, commissioners, for joining us today and members of the public. As Commissioner Cutler said, this is a really important mandate for the Health Policy Commission, and so while we were not required to hold a public hearing on this, we did think it would be very valuable for us to get the input of the community and the marketplace as we conduct this study. This is a study that has some urgency attached to it, as we understand that it is intended to directly influence the legislature and the administration's decisions to further extend the allowance of drug coupons in the Commonwealth in the future. And so very important that we get all of the feedback and input from all of the different stakeholders, understanding that this is a topic that with some controversy and some disagreements among stakeholders. So really interested in surfacing those today. We may have follow-on questions with certain stakeholders to the extent that there impacts our study design and research design. But with that, thank you, commissioners, for being here, and I will turn it over to Sarah Staunek, who is the Deputy Director for Research and Cost Trends at the Health Policy Commission, helping lead our work here to talk about what this study is, what our design questions have been so far, where we are in our timeline, and then turn it over to the public listening session.
Great, thank you, David. Good morning, everyone.
Good morning.
As David mentioned, I'll talk about our charge and what we're hoping to study, and to do that, I will go over some background, including the definitions that we are using, our framework, and our timeline, and the specifics of our charge. So, starting with with how we're defining coupons for the purpose of our analysis, we're talking about coupons that are offered by manufacturers for patients with commercial insurance that reduce the amount of a patient's cost sharing. Other common terms besides coupons might be called copay cards, might be called vouchers, and we're making a distinction for our purposes from programs such as patient assistance programs, maybe those offered by manufacturers, states, or nonprofits for patients who afford their medications. Those might be means tested or other eligibility criteria, but not generally available to every patient. Also, a distinction from cards or offers that are targeted for patients without insurance. That might be coupons offered from a company such as GoodRx. So that might be, for example, sort of deals offered by the pharmacies or special Walmart deals, etc. Again, this is for so it describes four categories here. The the branded drug, and for all intents and purposes, this is coupons are branded drugs. So the first is where the drug with the coupon has a direct generic equivalent. So Lipitor and generic Lipitor. Coupons for those drugs are not eligible in Massachusetts, cannot be used. The second category is one of particular interest for impacts on utilization. That's where the drug itself does not have a generic, but it has a competitor in its same category that is a generic. Um, so the third is where there are no generic competitors, there are branded competitors, and that one is has some challenges in studying because the comparators may also offer coupons. And then the fourth is where there are no closed therapeutic substitutes in the same category. This is what some term an orphan drug. So the patient has a coupon, but there are no sort of reasonably viable alternatives.
There may be non-pharmaceutical.
That's, I suppose possible. Most of the, I guess when you said that, what immediately came to mind is sometimes there are drugs in, sometimes there are drugs that have a over-the-counter alternative to a prescription. I think that though that type of scenario is less likely for this category. The typical things in this category are sort of typically high cost, sort of more for rare patients. Oh. Aha. Oh no. I hope you could hear all the early things that I said. Okay, and finally, reviewing the timeline for our work here, the phase that we're in is data acquisition from a number of different types of sources, including gathering information here today, and that also includes seeking to obtain commercially available data that may help us assess gaps in what we have from our in-house sources, particularly on the number of coupons and value, etc. We are planning to present preliminary results in July, and then finally release the final report at our September 11th board meeting. And I will conclude there and look forward to the discussion today.
Thank you, Sarah. I'm just wondering, it may be helpful while the presenters are giving testimony to leave up the slide, the previous slide with the 4 different types of prescription drugs, because my guess is some of that will come up in some of the specifics. So it may just be helpful for us to have it there. But I thought that was excellent, thank you. I have 4 names on the sign-up list, so I'll tell you what they are, but as I said, anyone and everyone is free to offer testimony today and submit written testimony by Friday at 5 p.m. So the 4 names that I have are Mike Calju, Sarah Gordon Cherry, I probably butchered Sarah your last name, Ziva Mann, and Alyssa Van Galen. But so others, so we'll take those 4 obviously first, and then others who wish to testify after that. Mike, do you want to come forward?
Good morning. Commissioner Cutler, Commissioner Berwick, Commissioner Blakeney, Director Seltz, and respected members of the Health Policy Commission staff. It's truly an honor to present testimony today on this important issue, one that has been in the policy debate for quite some time. My name is Michael Caljo. I am the Vice President of Government and Regulatory Affairs for Blue Cross Blue Shield of Massachusetts. We're a Massachusetts-based not-for-profit company committed to making quality healthcare affordable for our 2.8 million members and the more than 31,000 employers around the Commonwealth that purchase our products.
As you know, prescription drugs continue to show disproportionately high cost increases compared to the rest of the healthcare industry. According to CHIA's 2018 report, drug spending accounts for 19% of healthcare spending, but is responsible for more than 36% of the growth in THCE, total healthcare expenditures. As policymakers and stakeholders, we must find ways to reasonably manage those costs while still ensuring access to necessary treatments for patients. One of the primary tools employed by insurers to manage those costs is the use of tiered formularies. Formularies not only encourage the use of drugs that are both clinically effective and cost effective, but they also serve as a powerful negotiating tool. Manufacturers are often willing to decrease their unit cost in exchange for inclusion on a formulary, which brings higher utilization. Unfortunately, drug coupons are often used as a means to circumvent those formularies and undercut the ability to negotiate prices. Drug manufacturers often provide patients with discount coupons with the premise of helping to offset patient out-of-pocket costs. When using a drug coupon, an individual's consumer cost sharing may actually be lower for higher tier brand name drugs than for lower tier therapeutic equivalents. However, the combined amount that the insurer and the consumer spend for the higher tier drugs is substantially greater, raising the overall healthcare costs and premiums for all enrollees. In addition, after those savings expire, the consumer is left to repurchase the more expensive drug at the full cost share. Unfortunately, health insurers do not know when a member utilizes a coupon at the point of sale. Accordingly, carriers cannot use claims data to track the usage of drug coupons or their specific cost impact. However, a recent study published in the New England Journal of Medicine estimates that coupon usage increases the percentage of prescriptions filled with brand name formulations by more than 60%. The study examined 85 drugs facing new competition, 23 that offered coupons and 62 that did not. National spending on the 23 drugs with coupons was found to be between $700 million and $2.7 billion higher than it would have been if the coupons had not been permitted. In a 2014 bulletin, the Federal Office of the Inspector General noted that, and I quote, "When consumers are relieved of co-payment obligations, manufacturers are relieved of a market constraint on drug prices," end quote. For that reason, the federal government itself bans prescription drug coupons for Medicare and for Medicaid patients. We urge Massachusetts to follow that example. We have done so for some time. In the course of this study, which we think is a good thing, we encourage the Commission to take a close look at the type of drugs that offer coupons, as well as those that do not, and the resulting impact on prescribing practices, utilization, and cost. Thank you for the time today, and I'm happy to answer any questions you might have.
Thank you. I do have a couple of questions for you. And then my colleagues might as well. One is, do you know how the federal government enforces in Medicare and Medicaid that you can't use a coupon? How are they able to do it and not private insurers?
I think they enforce it primarily through the use of formularies as well, and in addition through guidance that they offer through both programs. I'm not aware of any other enforcement activities, but we could certainly go back and look and find that out for you.
And you couldn't do the same? You couldn't issue guidance to all the CVS agreements?
I think you could. I think the standing issue really is the state legislation that stands in the way of doing so right now.
So a coupon is a discount. So it's not the coupon that's the issue, it's the act of discounting that's the issue. For example, we can imagine a discount regime in which there's no patient doesn't bring in a coupon, but for the first 2 months of using the drug,
That's right.
discount. Are you opposed to the discounting process or the coupon?
consumer standpoint, the bait and switch aspect of the expiration of the coupon is a significant factor, and that should be taken into account by any report that you issue. In addition to that, the system cost issue, the sure premium impact issue, is impacted regardless of whether the coupon expires or not. It's a steady state issue.
I want to pick up on where my colleague Todd was and think about the second of those for a second. So, Sarah has that chart up here. So, there are a couple of reasons. Obviously, the coupons increase the use of the branded drugs. That's why they're used. Sometimes that might be good. For example, a patient is having difficulty affording a copay.
That's a necessary drug, it's the optimal drug for them, and making it cheaper for them is part of the case. And sometimes it may be harmful because, for example, in that third case that Sarah has, it may be switching, or the second case, it may be switching people from a less expensive drug to a more expensive drug for people that needs. Suppose, so I just want to ask you about an idea. Suppose the legislature said, you can go ahead and do that, but to the extent that it's determined somehow that what you're doing is moving people from a less expensive drug that's just as effective to a more expensive drug, the manufacturer has to pay money, not just for the coupon, but has to pay money to the insurer to offset that additional cost. Would that be an appropriate, would that be a reasonable thing? Would that, I mean, I just forget about the details of how you construct it.
Yeah, it's difficult to answer in the theoretical because I think the details really are really important. But assuming that carriers had a full landscape view of the use of a particular coupon, which they do not, one could imagine a scenario where that type of setting would be factored into the direct negotiation between a carrier or a carrier's agent and the drug company. Short of that, however, and given the fact that I don't think we have that landscape view, I think that there would be difficulties with that proposition theoretically.
Of course, legislature could require that information.
Yeah, I guess my issue would be a piecemeal approach to what is really a national in scope issue, and how would a state really affect change on that topic in that manner.
You mentioned that you have difficulty, even as a health plan, understanding when your members use these types of coupons, and that it is not readily apparent to the claims data when these things are used. I think we can validate that through our own analysis on the claims data. Do you think that health plans should have that type of information in terms of what their members are experiencing? Would that help in your negotiations or thinking around some of those relationships?
I think there's a value to having an amassed set of data on point. In sort of the theory that transparency is generally a good thing overall. So as an example, should the state aggregate that data and make it publicly available, I think that would have value for our clinical decisions, our negotiations, etc. I'm not sure it even needs to be as specific as per member. I think the aggregation of that information at large has value for policymakers and for insurers alike.
And just one follow-up question, just to be clear, to the extent that these types of assistance programs may shift patient behavior to a higher cost drug that is then reimbursed by the insurance company, where do you allocate those costs eventually?
Eventually, all the costs get borne by other members, by all members, right? So this is where I don't want to get lost in the specific member cost share question, although it's certainly a factor, we have to be mindful of that. But the larger system cost issue, like all the other system cost issues that you grapple with every day, get subsumed by the system. Right? It's one of the issues that face us, and so additional interventions, not less, would be helpful on this score.
See, that's why I was thinking about if the member gets a discount, maybe the members as a whole should also get the discount because it is increasing cost, which in some circumstances may not be appropriate to do.
Right. I think the issue that we would face in that circumstance would be, would the member cost be direct to a specific class of members? Would you be shifting them from a more effective drug to a less effective drug clinically? I think there are definitely complications to that, but theoretically, I think the premise is not a wrong one.
Just out of interest, does Blue Cross Blue Shield, either Massachusetts or association, have data, time trend data that would be helpful to the staff to show what's happened to drug costs when coupons click in at a state level?
I think we could find additional information. It would be time-based, right? Based upon when the coupon law went into effect and then went away. We'd be happy to share any other relevant data that's out there. I think it's probably captured, at least the claims-based data is captured through the APCD data that we're already available.
The study that I know of that looks at one that is due discounts on drugs for which there is a generic. I haven't seen comparable studies on sort of types 2, 3, and 4.
Is that New England Journal?
No, it's not. I don't think the New England Journal article is limited to those types of things. There's another article.
Thank you.
Thank you, Mark. Sarah.
Good morning. Commissioner Berwick, Director of Health. My name, can you hear me? I was getting actually emails from folks that have a trouble hearing online, so hopefully you can hear me now.
Just pull the microphone a little closer.
Is that better? Yeah. So my name is Sarah Caramita. I'm the Vice President of Legal Affairs, Public Policy, and General Counsel of the Mass Association of Health Plans. MAP represents 17 member health plans representing 2.8 million Massachusetts residents. We provide coverage in the Medicare, Medicaid, commercial, employer-sponsored plans, individuals purchasing non-group coverage, and individuals duly eligible for Medicaid and Medicare. And we appreciate the opportunity to testify in front of you today and provide information on the utilization and cost impacts of prescription coupons pursuant to your statutory mandate. So MAP and our member plans place a high priority on providing high quality and affordable health care coverage for Massachusetts employers and consumers. While significant effort has been undertaken to meet the cost growth benchmark and exceed it, there is still much more work to be done to improve the quality and affordability of health care in the state, and prescription drug prices continue to be one of the largest drivers of health care costs. These increases have been unsustainable and threaten the affordability for employers and consumers. The exorbitant cost of prescription medications creates a barrier for patients to receive the treatment that they need. MAP has historically opposed the use of prescription drug coupons in the market. While they appear to be a good deal for consumers on their face, in the long run, as we've heard today, they will lead to higher costs and fewer options for consumers, employers, and the state. While the consumer may pay a lower co-payment for a short amount of time, health plans pay significantly more for these higher cost drugs that are covered by the coupon. In our comments, we'll provide a lot more information and cite a number of studies that hopefully will be helpful. But I'd like to highlight a couple of our specific concerns relative to coupons and also make some recommendations for the scope and parameters of your study. Manufacturers use coupons to drive utilization of higher cost prescription drugs. We've heard that today, and I think it just is important to keep reiterating this. In analyzing the prevalence of prescription coupon use, the HPC should first examine when manufacturers issue coupons and when they don't. Coupons for prescription drugs encourage the use of more expensive brand name drugs when less expensive alternatives are available, including those that are soon to be coming off the patent. They're generally offered to consumers in connection with these more expensive when there are less expensive alternatives, not just generic. So I think we saw in your slides there are a lot of different alternatives in the market today, not just generics, therapeutic equivalents, less expensive or preferred brand names on a formulary, therapeutically equivalent brands, the generic of those, and biosimilars. So there are a lot of different options on the market, so I think we focus a lot on generics, but as Mike talked about, health plans use formularies to drive utilization to these lower cost, more effective and efficient alternatives. But let's look at when they're not available. They're generally not available for these innovative products with no therapeutic equivalents. And this is by design. A national study that we cite in our comments of retail pharmacy data found that enrollees in commercial insurance plans across the country use coupons for one out of every 5 brand name prescription drugs, and this was in 2006, and I think we have some updated data for you. For some brands, coupon use was as high as 2/3 of filled prescriptions. Another study of coupons for brand name drugs in which generics were available found that coupons reduced the rate of generic substitution to brand name drugs. With coupon offers, drugs with coupons had 12 to 13% annual price growth compared to 7.8% price growth for those without coupons. And again, this is in our written comments. As we've heard today, coupons are temporary and provide dubious benefit to consumers. While a drug coupon reduces the amount an insurer consumer has to pay out of pocket, it does not reduce the price a payer would pay for the drug. So as we talked about earlier, the payers are bearing the rest of these costs, and that in turn leads to higher premiums and impacts our ability to meet the cost growth benchmarks. So by inhibiting the operation of market forces that would have a dampening effect on drug prices, ordinarily that would drive prices down, incentivize them to have more competitive prices. Coupons allow manufacturers to increase drug prices beyond what the market would otherwise bear, and this again results in downstream impact on our premiums. Finally, as discussed, any financial benefit consumers may experience is temporary. If coupons are truly about helping ensure access to medications, as you've talked about, we actually agree that drug manufacturers should provide them for the duration of a consumer's prescription if it really is about access and not trying to drive utilization to high-cost alternatives. So as you've heard before, we are also, the MAP member plans are unable to track what a coupon is used at the pharmacy. Therefore, we do not have the ability to provide specific data to you about utilization in our market. Although we do have some recommendations for the HPC as you design your study. So first, we'd encourage you to look at generics, the use of generics pre-2012 and utilization of generics after the coupon. We know that the law specifically doesn't allow for coupons in the use, but because their coupons could be used prior to a drug coming off brand, it could incentivize members to stay on those drugs later when the generic is available. So we think it's important to take a look at generic use pre and post the law. Were there specific brand name drugs that saw higher utilization during this time and were coupons available to drug consumers? Even though we can't track it, we know when they're available. Were there particular types of drugs that were subject to the coupons, and were there lower cost alternatives to those drugs either on the market or emerging? And we have these in our written comments. And did manufacturers use coupons when the new drug was released or when a new generic version of the drug was about to enter the market? We think it's really important to track the behavior and the intent behind the coupons. And then finally, we'd like to have maybe an analysis of the duration of coupons. Are they really one time? Are they limited, or were any available for the duration of a consumer's prescription? So I'll take any questions, but we appreciate the opportunity to provide you with these comments.
Thank you, Sarah. Let me ask you a first question. So I understand that obviously why you use the cost sharing and so on is to steer people to appropriate medications or to the appropriate medications and so on. It's also the case that nationally there's a debate about whether cost sharing for some drugs, particularly very expensive drugs, is too high. So there's a little bit of a spirit behind the comments you gave and Mike gave, which are of the form, look, leave it to us and we'll get it right. But nationally, that doesn't seem to be the spirit. So is that incorrect? That is, should I say, should we have the view that, look, just leave it to the health plans and they'll get it all right? Or should we say, no, actually, maybe they're charging some people too much for their medications, and maybe the legislature should do something about that? And if the legislature should do something, maybe maybe some type of modified coupon program is a reasonable way to go. So how do I think through the coupons may be a bad idea versus I'm not sure I want to leave everything nationally? I don't want to talk specifically about coupons, but I'm not sure I want to leave everything to the insurers to decide the appropriate way to do it.
So I think your question is a couple of points. I think first, I think that all of this discussion just underscores the need to get prescription drug prices in line. Consumer cost sharing is a reflection of the underlying high cost of care. Employers and the state develop products with a combination of cost sharing and premiums that they can bear to help manage healthcare costs. So until we start to get underlying healthcare costs in line, I think we're going to continue to see increases, but we're also going to continue to see some cost sharing to alleviate the burden on employers. health plans, as we heard, as Mike said, and we agree, formularies are one tool to try to incentivize utilization into products that we can to have the best price, are effective for our consumers, and trying to manage overall healthcare costs. So we need to be able to utilize formularies to help control healthcare costs. Coupons do lessen our ability to manage those. That I think until we get prescription drug costs and spending in line at the national and the state level, I think we're going to continue to see that those pressures continue. So I think it just underscores the urgency of trying to find solutions to manage and address prescription drug costs.
But if we can't do that as a state, does that mean that we shouldn't do any? We shouldn't allow any? Right? Like let's say, like nationally there are stories of, needed medication, maybe the cost sharing might be $8,000 a year.
Well, as I said in our comments, I think we would be open to, if those are necessary for patients, requirements that they provided for the lifetime. There's a reason that they're not provided for the lifetime of the prescription, because they're not intended to be truly an access. They're intended to try to incentivize and have consumers become accustomed to a particular brand. So I think we need to take a look at how they're being used, and if that is a requirement, then I think your comments earlier to Mike about are there other ways that we can try to get plans and manufacturers to come with new agreements. I think we'd be open to have, I can obviously answer that as an affirmative on behalf of our members today, but I think we're definitely open to conversations, but let's take a look at how they're being used. And if I don't really necessarily think it's a true benefit to consumers if it's really only one time.
Let me twist part of it. There's no right answer to the question I'm asking. I'm just building on David. So let's take Sarah's slide about the $300 month. And a patient comes in testimony here today and would say, right now, that month, I got a $300 benefit. I can't switch to a generic or my doctor wants me to have that medicine, and you are considering taking away that $300 benefit. Do we have any realistic answer to that patient that helps?
So I definitely sympathize being in that position myself. But I think that we have to be honest in that, yes, that one time I think is that the patient's going to see it as a benefit, but it's going to show up in healthcare costs in the system. It's not just limited to that instance where the savings is. And I think that we need to have a broader solution, because what it is, it's driving overall utilization of these really high cost pharmacies that's going to be borne in that patient's premiums when they go to enroll. So I think it's very tempting to say, okay, yes, we will provide 1 month of relief, and for a lot of people, that's a lot. That's really meaningful. But when it comes in the form of higher costs down the road, and the system really can't bear it anymore, I think it's worth a broader conversation about what we do to manage cost prices.
And I guess I would add to that point, in thinking about the real affordability challenges that patients are facing at the point of sale for these pharmacy drugs, there is also the fact that the health plans are negotiating significant rebate arrangements with manufacturers. And adding to this conversation, is there efforts that your plans are making in terms of thinking about how to actually translate some of those rebates down to patients at the point of sale? Obviously, there's a federal proposed rule on this topic, but that is another place where, in this case, the plans are benefiting from some of those negotiations, and again, the patients aren't necessarily seeing the benefits. So I want to add that wrinkle to the table.
And see, let me just build on that for 1 second before letting you answer, giving you time to think about the answer. The reason why I asked the first question that I did is because what we've seen in a lot of healthcare, nationally, again, I don't want to talk about this, just nationally, is employers want to keep their premiums low for the vast bulk of their employees, and they're willing to sacrifice high expenses for those few who are very ill. So you take people who have very severe chronic conditions, MS, rheumatoid arthritis, so on, for which the medications are super expensive, we have very high cost sharing for them, and in exchange, the premiums can stay low. So I think what there's been is a shift in spending from people like me, who thankfully don't need any of those, to my less fortunate peers who need more of them. And that's been a trade-off, and I'm not sure that's the best trade-off, for society as a whole, for the country as a whole. But then if you think about what impact any policies Massachusetts does, we wouldn't want it to add to that situation where what happens is we increasingly transfer costs to sick people, and people who aren't in that circumstance relatively benefit. So I think that's exactly this spirit.
And that's part of, obviously one of the tools of the formulary is to negotiate rebates and discounts for volume, and that's to try to drive volume to get a better rate. If we could find ways to, again, lower the list price, and that would further transfer those savings from the rebates and built into premiums for the next year. So it's a constant discussion as to kind of balancing how to get those costs down. So I think we're definitely open to other and willing to think through other creative ideas. We just don't believe that single-use coupons or even temporary use coupons are really the way to go in the long run to try to drive down healthcare costs. But I think it continues, as I said, underscore the urgency of addressing high prices in the pharmaceutical space.
Thank you. You just set up my comment very nicely, so thank you for that. I think underpinning all of this sits a value statement. You know, what are our values and what's important? And we can try to address the issue of coupons, but the underlying issue is cost. The underlying issue is what drives cost in pharmaceutical companies, what should be reasonable, and what is not reasonable, but we haven't addressed it. And so as we think about coupons, and we think about what the industry is doing to incentivize people to make decisions that are not necessarily in their long-term best interest, and how prescribing clinicians, what role they might have in having these conversations. Because while the plan might not know that a coupon is being used, the provider may. And so where is that conversation, and what is the education of the impact of that at the level of which the decision is made to use this medication versus that medication based on all of the efficacy and everything we know about the patient and about the patient's response to the drug.
I think that's a really good point. I think that's a really important point that I think all the stakeholders have to come together. I think, again, it underscores the importance of transparency, which we've also supported, and we know that the commission's included in its recommendations is understanding the makeup of these prices, how we get there. But having information across the market, I think, is really important.
Thank you.
Thank you very much. Any other questions?
Ziva Lian is our next presenter. I now understand, I think, David Seltz, are we allowed to bill the legislature for the aspirin that we will consume while
Charge them.
Yeah.
Is there a coupon?
That's great. Can we get a coupon for it? Thank you. Bring the microphone as close as you possibly can.
Okay. Can you hear me now?
Yes.
Commissioners, Director, thank you. So I'm here today on behalf of Massachusetts Bleeding Disorder Community and the New England Bleeding Disorder
So
Advocacy.
try and swallow. I just want, because there were reports of people on the Facebook can't hear you, so I want to make sure that everyone can actually hear you.
Fair enough, and I do have a quiet voice, especially when I'm a little nervous.
Okay.
All right. When I start to talk.
Yeah.
It's true. Thank you. So I'm here today on behalf of the Massachusetts Bleeding Disorder Community and the New England Bleeding Disorder Advocacy Coalition, NBDAC. And I just wanted to thank you for the opportunity to share our perspective on this issue. So my name is Ziva Mann. I live in Newton with my husband and two boys, aged 13 and 17. NBDAC submitted some written testimony, and I'm just going to speak to what I understand from my own experiences as a parent and as someone who's worked in primary care and done a little bit of work with Institute for Healthcare Improvement on system redesign. So my 17-year-old Shai has severe hemophilia A, and as I learned after he was born, I have mild hemophilia A. So for those of you who skipped that one tiny paragraph in medical school, which actually has since changed, hemophilia A is a genetic condition by and large, and there is no cure. Shai was born with it, and he has severe hemophilia, which means that his body is completely missing one protein in his blood, so he doesn't clot normally. This means that he is at risk for spontaneous bleeding into his muscles, joints, most terrifyingly his head. This kind of internal bleeding can lead to long-term damage, disability, and death. In Massachusetts, there are about 750 people like Shai. There are 67,000 living with other kinds of bleeding disorders. Now, before the clotting medication to treat hemophilia, it's called Factor, was invented in the 1960s, kids like Shai didn't live past age 11. Today, Shai has clotting medication that works for him, and we expect him to have a normal lifespan. So every other day, Shai gets up, he showers, he brushes his teeth, he eats breakfast, and gives himself an intravenous infusion of about 2,000 units of clotting medication. Thanks to his Factor, Shai has played varsity soccer, was the lead in a number of his high school plays, and is currently sweating his way through his AP tests and finals. If he skips a dose of Factor, he pays for it, usually with painful internal bleeding. It's not uncommon for him to come to the dining room or the kitchen where I am and say, I think I forgot to infuse today, and like be holding his elbow. So the problem is that Shai's medication and all Factor medication are very expensive. So the average cost for an adult with severe hemophilia is $350,000 a year for medication. Shai's regular every other day dose costs approximately $2,000, which adds up to about $365 per year in medication alone. That's preventative. Copay assistance is coupons allows families like mine to cover high out-of-pocket costs associated with Factor. Because of the high cost, many folks in our community hit their out-of-pocket max on their insurance in the first shipment of Factor. I spoke to a mom of a little boy, 3-year-old boy called Colin, who said that they hit their out-of-pocket max on January 3rd of this year. So that would mean that without a copay assistance, we'd have to pay all of that money in January. So for my family, that would be about $8,000. And that's a lot. So this past January, give you a little case study, I was grateful that I had copay assistance to cover the cost of Shai's Factor. My younger son needed epinephrine, generic epinephrine, that was $371, the generic. I did not actually have copay assistance to help cover the cost of the medication that treats my mild hemophilia, and I had to make the really painful choice not to fill the script, which is a little embarrassing for somebody in my position. We just didn't have the extra $717.81 to spend on meds, and as a person with mild hemophilia, I decided to roll the dice and see if I could get away with it. So far, so good. Please do not tell my 17-year-old. In our community, our clotting factors are all name brand biological products. There are no generics. People respond differently to different brands. So we work with our doctors to understand how Shai's body responds to his clotting meds, how fast he metabolizes it, and that's how we decide what brand of factor to use and how much frequency. Because all of the current manufacturers of Factor products offer the same level of copay assistance to the bleeding disorder community, that discussion with his medical team decides what medication he uses, not copay assistance. Copay assistance just covers the costs. It enables consistent treatment, even in January and February. Now, when I worked in primary care, and this is part of why this is so humbling, I've seen many other people do what I'm doing now, trying to stretch their meds, rationing. It's the kind of savings that we all know tends to cost more in the long run. In the bleeding disorder community, poor access to recommended treatment means that before long, we see someone trying to manage a bleed that wasn't treated right away. It's much more expensive, it's much more debilitating. You end up with long-term pain damage to joints, pain management, lost work or school, everything. Our treatment plans and that conversation with the provider are designed to avoid. We know that the cost of healthcare is a problem, and we really believe that solutions need to be found. As individuals and as a community, we're doing everything we can to make the right choices. We work with our doctors to balance costs and a full healthy life. We learn how to stick needles in our babies' veins at our kitchen tables. We teach our kids how to use a needle when they're 6 or 7 years old. Shai, at this age, is actually a role model for other kids, bringing them into a peer-driven culture of health. We know our meds are expensive, and the consequences of not having these coupons, the consequences of not having access to the right medications. It is literally a matter of life or death. So as you make your recommendations to the legislature and you go forward in your study, please keep in mind that for our family and our community, copay assistance programs like these give us access to the medications that kids like my son need to lead a full, active life. Thank you. And I'm happy to answer any questions. That was the hard part, so I really can't answer questions.
Well, thank you so much. That was very moving testimony. Thank you. Can I make sure I understand? I just want to understand, I think, something you said. In your case, you'll wind up hitting the out-of-pocket max in your insurance at some point during the year.
We hit it every year. We have an FSA, and we empty that out every year as well, which is usually why I run into that problem in January.
So the primary thing that the copay coupon is doing for you is it's sort of stretching out the payments so that they're not all happening in January?
Yeah. Because otherwise, I would have gone to the pharmacy and forget just the flogging factor, right? The generic EpiPen plus my own script was $1,000 and change.
Yeah. So there's, in some sense, there's a failure here of the insurance company to recognize that you're going to hit your maximum, so charging it all to you in January is just not that sensible thing to do.
Right.
Because you're going to, if they let you pay some of it in March, that's what difference does it make?
Yeah, we don't have, I mean, I can't speak for, the whole community, but I don't have an objection to paying my fair share, right? We budgeted for it. We very carefully chose a healthcare plan that we could afford, the premiums and the out-of-pocket maximum over the course of the year. We just can't afford it all up front.
Thanks so much, and you did great. Is there a difference between what you're calling copay assistance and coupons? It's just the same thing.
Same thing.
And your coupon doesn't expire. This assistance is going to be there as long as you need it.
My understanding is that there's a cap on it. So the epinephrine, I got to have it calling it EpiPen. The epinephrine coupon is a once per year use, which is a little tricky because, we need more than one set. But the clotting factor coupons, there's a limited number of them. I think there's a maximum per year. I'd have to double check, I can tell you.
Thank you very much.
Thank you.
Alyssa Benjamin.
Good morning. Commissioners, Director of Health, members of the Health Policy Commission. Thank you so much for the opportunity to provide oral comments this morning. My name is Alyssa Vangeli. I'm co-director of Policy and Government Relations at Healthcare for All. Healthcare for All advocates for health justice in Massachusetts by working to promote health equity and ensure coverage and access for all. As you can imagine, this is a really difficult topic for us and one that I haven't been looking forward to testifying on this morning, but thought it was important to be here to share our perspective with you all today. So as a consumer health advocacy organization, as you can imagine, we have a very strong interest in ensuring that prescription drugs are affordable and accessible for residents of the state. In fact, affordable prescription drugs is one of our top legislative priorities this session. And we also understand that some patients and consumers truly rely on prescription drug coupons and rebates to access medications that they need, would otherwise not be able to afford. And we don't believe that such access should be disrupted. However, we do continue to have concerns that drug coupons can increase the cost of healthcare overall and should not be viewed as the solution to addressing high and rising drug costs in the state. So as we've already discussed, drug manufacturers offer coupons and rebates to consumers to decrease or eliminate out-of-pocket costs for certain high-cost prescription drugs, where the health plan still pays the higher cost of that drug. Through coupons, drug companies can incentivize the purchase of certain high-cost drugs when other options are available that are cheaper and potentially equally as effective. This chart is also really helpful. Thank you for providing that. And we know that, while in Massachusetts, the coupon use has been restricted to where there's no generic equivalent, coupons are still available when there are therapeutic equivalents or other alternatives. We do have concerns that were shared earlier that coupons are often limited on a time-limited basis, or offered on a time-limited basis, do have expiration dates, and we hope that the Health Policy Commission is going to be looking into that and the impact on consumers when they're left paying the full out-of-pocket cost when a coupon does expire. And I guess I will just say that, overall, we're grateful that the HPC is taking on this study. When we were looking into this issue back in 2012, when the law was rolled back, we were strongly advocating for a study to be conducted a year or two after the law was passed. As you all know, the Division of Healthcare Finance and Policy was supposed to conduct that study, which is now under organization. So we're really pleased that the HPC is now taking this on, which will hopefully help inform the legislature as they're making a decision about whether to allow coupons to be continued. So I will just conclude by saying that while the high cost of prescription drugs continues to be a problem for consumers and payers and businesses, we believe that undermining cost-effective prescribing through drug coupons should not be viewed as the solution, and we really urge both drug manufacturers and policymakers to look for long-term sustainable solutions to addressing high prescription drug costs in the state. Happy to answer any questions.
So thank you for the testimony. If you were advising the legislature as to whether to continue the allowance of the coupons or to go back to the pre-2012 regime, what would you advise them?
So I think we would want to first have a better understanding of how coupons are being utilized here, what the impact has been on cost, on patient adherence, on out-of-pocket costs. I think, again, having a better understanding, hopefully the information that the HPC will help to generate here. I'd say, again, our three main concerns with using coupons is the impact overall to the system in terms of increased cost of premiums, the fact that coupons are typically, we understand, offered on a limited short-term basis, so I think better understanding that, and then the point about, really not looking at coupons as the solution and not distracting that from the efforts that really need to take place to address the underlying cost of prescription drugs. So I was intrigued, Commissioner Cutler, by your recommendations of, if coupons are going to be offered, potentially making sure that manufacturers are giving the same percentage or dollar amount to the payer. That's an interesting idea. Maybe do that in conjunction with making sure that coupons don't have expiration dates so that people are really benefiting from these coupons on a long-term basis. So I think, if some of these concerns were to be addressed in creative ways, then I think we would certainly be open to that.
Just to be fair, the only single word I would disagree with is where you said recommendation.
Oh.
Just suggestion.
Not recommendation, something to consider.
Something to consider.
Yes, my apologies, yeah.
And I would note many of the topics that you just mentioned, are contemplated as part of our study, and we do expect to be able to have some information to put forward. I would say, we heard powerful testimony today about having, residents really struggling with the cost of prescription drugs and making trade-offs in terms of being able to afford that point of sale for themselves or for a family member. And I know that's something that Healthcare for All truly does care about. And you can get a lot of phone calls of people, wrestling with being able to afford their medications, regardless of this coupon issue. And so appreciate your continued partnership as we think about the real affordability challenges that many members and residents face. And I know that continues to be a value that your organization holds in terms of trying to find some solutions.
Absolutely.
I think you heard all three of us struggling with exactly those same issues.
Yes.
Thank you very much.
Okay, thank you.
Those are the four names for individuals who signed up to testify. Is there anyone else who wishes to testify? Let me thank those who did offer comment. Thank you very much, and for being patient to answer our questions. I appreciate that. Let me just remind everyone that we will accept comments until this Friday, May 24th at 5 p.m. by email. And the email address is hpc-testimony@mass.gov. And you can also find more information on the HPC's website about this report, about submitting testimony, about many other things. So if nobody else has anything to add, we will adjourn the meeting. Thank you, everyone.
And we will post that, all the testimony online as well.
Yes, thank you.
Thank you.